Good evening, aspirants. Today's class is on psychiatry, MRCP, and it will be taken by Dr. Hassan. Sir, I hand over the class to you. You can begin the class.
Let's go with the lecture. First, we need to know what is hallucination. Though I know that all of you know about these hallucinations, but a little bit you need to know so that you can clarify the diagnosis actually. What is hallucination actually? It is a sensory perception which is that occur in the absence of external stimuli. So external stimuli will not be present there. No, there will be nothing else. Just patient will declare you about his experiences. Like I can see some tigers, I can see some sort of instruments, I can see some sort of anything, any objects you can see. So this is very much important one. So there are some features you should clear about hallucination. That what is the difference between hallucination and the imagination? Can anyone tell that imagination and hallucination, just how you can, make a difference between these two things? Imagination, we can all imagine with ourselves. No, you can imagine a dream and anything else. But what is the difference between this hallucination and imagination or dream? There is some difference you can see. Like
We have
hallucination.
insight, like we know
Yes.
that we are imagining.
Yes. Yes. Very nice. That is yes, and also you can do anything with your imagination. Like you can imagine what you are favorite for. Like you like a player from your country, so you can imagine him, no? And you can imagine your mother, your father, all of them. But the hallucination, you cannot be imagine as yourself you want to, because it's a disease. That hallucination is not normal. That's why I'm saying. So look, the characteristics: perception without external stimulus. There would be no any object. There would be no object, and then you can see that vivid and clear. The experience is real and it is clear, and it is involuntary. That is the important thing. Imagination you can imagine at any moment. That is voluntary, but it is involuntary. This is very important. Involuntary perception. So sometimes they would not describe you in the scenario that it is hallucination. They would describe it as a involuntary perception. You should be clear in your mind that is a hallucination. If you don't understand the question, you could not go for the answer. So involuntary perception is known as hallucination. If any question, in any question you can see, that is not real, unreal things, but patient seems it is real. Patient can tell you that it is real. Occurs in any sensory modality, like visual, auditory, mostly auditory hallucination, visual, and another tactile. These three is very important for us: tactile, visual, and auditory. No, visual hallucination, anything he see that other people don't see. Auditory hallucination, anything he hear, other people don't hear. So anything you sense, other people don't sense. So these all are the things about hallucination. So this is very important. I think you will just go for the reading these criteria, then you can understand very easily. Next, go to the these are the descriptions I just described here: auditory, visual, tactile, olfactory, gustatory. You should know about this term. Auditory means hearing sounds and voices, someone whispering in your ear. So you can just hear it by two sounds, three sounds, a lot of sounds you can hear. Then visual, seeing objects, people, patterns that are not there. Tactile, feeling some sensations in touch and pressure. Tactile hallucination is very important to diagnose a disease like alcohol withdrawal. We will come to these pathologies. Alcohol withdrawal symptom, one of the features, that is tactile hallucination patient will feel. Some insect crawling around the beneath the skin. So insects, you will feel insects beneath the skin. So you can find that is tactile hallucination. Mostly it is alcohol withdrawal. Other things, there is some amphetamine induced can happen. Olfactory smelling odors that are not present, okay. Gustatory tasting things without external stimuli, okay. We know the we know these pathophysiologies and these terms. Now we will go for the third person hallucination. Do you know what is third person hallucination? First person, second person, third person. Very, very important for us is third person hallucination. Just read it here. I have described it. That third person hallucination is an auditory third person hallucination. Yes, it's an auditory third person hallucination in which an individual hears voices speaking about them like anyone. He or she tell you, like you are just having a discussion with your friend, that you are telling that he asked me to do this thing. Who is he? This is third person. Who is she? Or any type of objects, or any someone. You can tell it someone. Someone says me that I have to do this, or I am the king. Someone told me that I am a king. So someone whispers in his ear that he is a king. So this someone is third person. This is third person hallucination. They will tell you in the scenario that someone tell him that he is a king, and it is whispering in his ear. So it is third person hallucination. This is pathognomonic, and this is very important for which disease? Schizophrenia.
Schizophrenia.
Yes. So you have to identify from the from the question stem that what is third person hallucination. They will tell you that this someone tells the patient that he is a king, or he is going to die, or any bizarre things. But the voice, that is a voice. You should keep the mark that is a third person voice. A third person voice. Just a third person voice. Okay. So now we know about the third person hallucination. Whenever I just repeat these things, you will understand that this is a third person hallucination. So it would be easier. Often associated with schizophrenia. Now there are some hallucinations came in exam, that is haptic hallucination. Very important one. Haptic hallucination. Haptic hallucination. Sorry. Haptic hallucination. Haptic, you should know the term. Look, insects are crawling beneath the skin. This is one of the tactile. This sensory tactile hallucination also, but it is known as haptic. Haptic, haptic hallucination. Most common in alcohol withdrawal symptoms. Again, cocaine abusers, amphetamine abusers also can see, and schizophrenia is also can do that. But very, very important one is alcohol withdrawal. This is very important. Whenever you found that, you should go for the alcoholism, whether the patient is alcohol dependent or not. Then you can answer it as a alcohol withdrawal syndrome. So haptic hallucination, they sometimes can write in the question that haptic hallucination is present. So if you don't know the haptic term, you will be in danger, or you will be in difficulty. So haptic hallucination, you should know the term. Again, another one, hypnagogic hallucination. Hypnagogic, hypnopompic. Transient hallucination, visual, auditory, tactile, occur when patient going to sleep. This is part in sleep disorder. If you are going to sleep, then you can see some hallucination that is transient. This is hypnagogic. And there is some sleep disorder where hypnopompic hallucination. It is at awakened moment. Whenever patient is awake, then he can percept. This would be a transient. Patient will recover spontaneously. So these are the term of hallucination we know now. Let's go. Delusion. What is a delusion? You all know about delusion. There is a lot of talks, but we need to know the which one. It is a false belief only. Only these things, if you know, then it will be easy. It's a false belief. So it is not normal. False belief. That is not evidence. That is not that can be contrary to any information. That can be resistant to his cultural terms. So anything else, just a delusion is important. Psychosis. Important part of psychosis, no? Delusion and hallucination, these two. So let's go. You will read it in your other time. Now, what are the types of delusion? You need to know about the types of delusion. Look, here, this is very important. One of the type, that is delusion of thought possession. Thought. Sometimes they will give thought insertion, sometimes thought withdrawal. There is a thought. that thought possessions delusion can happen. Anyone being controlled uh, by anything, like he could say, the patient could say you, told you that I have been controlled by this alien. So that is external force. This external force is forcing the patient. So this is a delusion. Alien could not forcing his legs or arms like that. So this is type of delusion, that unrealistic talks. So that can causes delusion. Okay. So delusion of thought possession, like what are the thought possessions? That thought insertion, thought withdrawal, thought broadcasting. These three important features are very important for schizophrenia. And you know that thought insertion means any belief that being placed the person's mind by external source. He can say the external source could be a robot, could be his supernatural force, could any technological device like mobiles. So these all are the things we will be in the scenarios. So we will come with the scenarios, then we can very easily deny it. The person feels that, look, one of the example here, person feels that these thoughts are alien, do not belong to them. The thoughts are alien also. So this is thought insertion. Thought withdrawal, that object or that alien can uh, just deny his mental content or his mind's thinking. Suppose you are thinking that you want to go for the playing football, but the patient is saying that I could not play football because the alien reminds me not to go. So this is thought withdrawal. So something unreal, something unrealistic, we need to understand. Thought withdrawal and thought insertion. Thought broadcasting is same, that someone is hearing my all thoughts. That is thought broadcasting. So someone is hearing all the things. Someone is reading my thoughts. So this is thought broadcasting. Just you would know by having some reading here. So now participatory delusions, there is grandiose delusion. You know, grandiose, very important. Grandiose means I am the king, I am the big person. So I know all the things. This is grandiose. So grandiose delusion of grandeur. This is most common in case of mania. There are some common things which are most commonly, can be a feature of any disorder. So grandiose delusion is a feature of mania. In mania, if there is any psychosis, mostly these patients suffer from grandiose delusion. So you need to understand. And delusion of possession like thought insertion thought, that is schizophrenia. Schizophrenia mostly delusion of possession or reference. Delusion of reference. Reference means any kind of robot, any external force is forcing you not to do this or have to do this, or they are reader of your mind. The external source is a reader of your mind reader. So this is delusion of reference. So delusion of reference is schizophrenia. Delusion of grandiose is from mania. So you should remember these things specifically. Then it will be very easier. Believe me, it will be easier. Erotomanic delusion. Erotomania, you can see that someone in higher in love with the person. So that is erotomanic. So it's easy. Somatic delusion, the belief there is something wrong with the body, being infested by parasites. So that is somatic delusion. These are very easy things, I think. Now this is the time you can read. Any one of you can read. What is this? Dr. Deepasri or anyone?
No. A 30-year-old man with schizophrenia has been walking around wearing a mental helmet and has covered all his windows with tin foil. Sir, can you hear me?
Yeah, I am hearing you.
Okay.
Yes, it's clear.
Okay.
Thank you.
Then covered all the windows with tin foil. He reports that this is to stop his thoughts leaking out of his head and being read by others around him. What is the
Yes.
symptoms called? Auditory hallucination, thought blocking, thought broadcasting, and thought echo, thought withdrawal. Okay. So,
Mind reader. Mind
yes.
reading. Mind reader is broadcast. Something
Yes.
broadcasting.
Thought broadcasting.
Yes, thought broadcasting. It is one of the common thing in schizophrenia. Schizophrenia. So thought broadcasting will be answer. What is thought blocking? You are reminding of you have something to do, but he
Yes,
is
but
not.
cannot express.
Yes, cannot express. Yes, by why cannot express? Because he reports or anyone just misleading him. That is
Yes.
the thing. Okay, thought
Okay.
withdrawal. You are thinking of something, but he is not.
Uh-huh.
He's not going to do. He's not give you permission to do that. That is the thought
Yes.
withdrawal. So these things is very little thing, but you need if you understand that would be easier. So let's go now.
Thought blocking is our.
Thought blocking, yes. The mind, your mind will be stopped. They will stop you
Yes.
to give you any speech. That is thought blocking.
Yes.
Okay. Here are some descriptions I have provided in this lecture so that you can read it because it is part of your syllabus. That's why I am giving it. If you read my whole lecture, I think you will pass 100 by 100 in MRCP part 1. Even MRCP part 2, you can do good. Here are some delusion experiences. Look, delusion of reference. Believe that special meaning lies behind something innocent, public domain, songbook, newspaper, TV. Delusion of guilt. No, it is delusion of references. It is not guilt. Guilt is guilt. Guilt, we know about the guilt. Patient is feeling guilty. That is guilt. That's why I am not giving this elaboration. Delusion of reference is these all the reference actually. This thought insertion, thought blocking, thought broadcasting, thought echo. All of these are references. Nihilistic delusion. Negative belief of oneself. Yes, fully negative thoughts. Like any depressive patient having delusion, that is nihilistic delusion. Okay, a depression person. What are the depression signs? You know, depressed mood, low mood, eating poorly, eating heavily, neglecting herself, cannot sleep, hypersomnia, excessive sleep. So all of these criteria are depend on the are involved in the depression. So in case of depression, if a patient for the depression having delusion, that is named as nihilistic delusion. That is negative belief that I am worthless. That is a negative belief. That belief is a delusion. And he will talk with you with the confidence that I am a negative person. So that is negative nihilistic delusion. Okay. So this delusion is important. What is obsession? Obsession. How you can describe obsession? Obsession is a repeated senseless thoughts that causing you repeated working, like hand washing. You are imagining that you have soil, you have some dirty germs in your hands. This is a thought. This is obsession. And compulsion, what is? You are going for the work, regular washing your hands in the shower for 1 hour. This is compulsion. So obsession, compulsion, repeated work that you could not deny. So this is also involuntary sometimes. You know, your mind is preoccupied by your obsessions. So if mind is preoccupied by obsessions, that is obsessive compulsive disorder, OCD. Very, very important to know. A lot of questions over there with the obsessive compulsive disorder. Okay. We will describe it here in the lecture. Okay. Let's go. Now, schizophrenia, why it is occurred? Why schizophrenia occurs? There are no other things. Actually, there are older neurotransmitter theories. There are a lot of theories actually, but newer theory is like this. This is the newer theory. Look, the newer theory. This is important. Glutaminergic neurotransmission, hippocampal aspartate receptors. You need to know this only. Memorize this actually. That hippocampal problems are going to face this schizophrenia patients mostly. So this is unknown why this is happening, but there are some risk factors to happen like this. So this is very important. Some structural changes you can see in MRI, that is hippocampal, parahippocampal area, thalamus area, temporal gyrus, frontal lobes, all of these areas are important. So we have to know the green zone is the question zone. Okay, this is a question you need to know. Older theory, there are some neurotransmitter problems, and newer theory, there is some problem with the glutaminergic neurotransmitter hippocampal area, that is N-methyl D-aspartate receptor. So you need to memorize it only. Let's go next. Epidemiology, just you read it in which early to mid 20s and late 20s in women. can suffer from schizophrenia. So A, B, C, D, you can learn with the A, B, C, D, or you can learn with D, H, D, D. So these are the mnemonics, or you can, if you understand, I think no mnemonics needed. So there would be a delusion, that is delusion of reference mostly, and thought insertion, thought broadcasting, thought removal, withdrawal, thought echo, all of these are present in the schizophrenia. Okay, now you all know about these things: thought insertion, thought withdrawal, thought broadcasting. These all are the delusion. Okay, delusion of reference, as I told you earlier, the delusion of reference. These all are the things, delusion of reference. If they said in one term, that is delusion of reference. So these are thought insertion and blocks. Hallucination, now you know which third person hallucination. Now you know that hallucination, that is third person hallucination, will be a external stimulus will having whispering to your ear. You can see in some movies like these problems patients suffer. So now we can go for disorganized speech. Can be happen sometimes, disorganized speech. Negative symptoms. You know the positive symptoms. What is the positive symptom? These two are positive symptoms. Whenever the positive symptoms you think, that is delusion and hallucination should be come you in mind. And negative symptoms, patient is blunted, apathetic, that is blunted affect, apathetic, poverty of speech, poor motivation. Like a silent person is like negative symptoms. If you are talking with one person, that person is remain silent and no speech uttered, so you can say you are very negative. So by this thing, you can just memorize those things. He is very negative. I have asked it's lot of questions, but he's apathetic and he could not answer anything. So it is something that is pathological, you know. But you will treat which symptom? By positive symptoms you will treat. And we have read in previous lecture, positive symptoms treatment are which drugs? Antipsychotic drugs. You know the mechanism of action. Antipsychotic drugs mostly effect on the positive symptoms, not on the negative symptoms. Little negative symptoms will be helpful with the atypical antipsychotics, but mostly we will treat the patient for the positive symptoms, because delusion hallucinations are very dangerous. Patient will go to suicide after this. So that's why these are the very severe, that positive symptoms. But these negative symptoms would not go for the let him go for the suicide. You know, negative symptoms, patient will just poorly motivated and poorly. But positive symptoms, if a patient suffer, he will just go for the suicide. That's why we need to treat it. This schizophrenia is very dangerous. You should admit that patient is diseased. You should treat it.